are Bristol Myers Squibb, Amgen Oncology, Genentech, Adaptive Biotechnologies, Sanofi, Oncopeptides, Karyopharm Therapeutics, and Takeda Oncology. So today we are going to be speaking about navigating neuropathy, and we're going to have Dr. Kelsey Barrell, who's a neurologist, speak to us on that point. But I know before we wanted to launch into that, and before I formally introduce her, I'm actually going to stop presenting and turn the time over to Nico. For those of you who don't know Nico, he's the social worker as part of the Huntsman in the Huntsman Cancer Institute in the myeloma program. So I'm going to turn the time over to him to introduce himself briefly, and then he's going to introduce the Baileys, have them speak, and then we'll hear from Dr. Barrell. So I will stop sharing, and Nico, the time is now yours.
Great. Hi. Thanks for joining us. So today, we're going to hear from Dr. Barrell. For those of you who have come to our in-person Huntsman
Nico, I think you muted yourself.
Sorry. Thank you.
Okay.
Hi. I'll start again. I'm Nico. I'm the social worker who works with multiple myeloma at Huntsman. And I asked Dr. Barrell if she would be willing to come and speak to us again. She's spoken to us twice before when we were doing in-person education groups, and she's just terrific. So I'm really glad that she could join us. And she'll have a presentation, but there will also be an opportunity to ask questions. And we'll kind of manage that based on how many people we have and how many questions we have. But we are interested in answering patient questions. And then with this kind of new format of doing this virtually, having a lot of people, which is a great thing, I kind of wanted to give a sense that, this is really about individual patients. And since the format doesn't so much, allow for as many people as we have to interact one-on-one the way we would in a small group, maybe person to, in person. I wanted to just highlight a few, one or two myeloma patients and caregivers before each meeting that we have, just to kind of, focus our attention on the individual myeloma patient experience, which I think a lot of us can share, or a lot of you can share, and that I get to share as a social worker working with you guys. So I asked the Baileys if they would share their story, and I won't spoil it. That's my son. I'm actually away from the office today. So I don't know if the Baileys are on the call, but if they are, then I'll just kind of turn it over to them. But thank you very much, John and Anne, for joining us.
You bet. Go ahead.
Okay, we're on the call and we're here. Are we?
And you got a cute son.
Thank you. They say you're cute. Hey.
Can you hear us?
Yes, we can.
Are we coming across? Okay. I'm an 18-year survivor of myeloma, was diagnosed in the year 2003. We received our early treatment at the University of Arkansas. And I would just like to share with you of 7 or 8 perspectives that I have learned along the way. If any of you watched the little preview prior to this, listening to Roz and to everyone else that talked there, they've made some of the points that I'm going to make. But I had a high school history teacher who said, if you read something the first time, you're apt to forget it. If you go over it the second time, you'll remember it a little bit longer. If you review it and fix it in your mind, it's yours forever. There's a lot of things I learned in high school. I've lived long enough that I've forgotten more than I ever learned, probably. But with that, I won't feel uneasy about repeating some of the excellent points that were made in that preview. I think the first thing I'd like to share with those of you who are recently diagnosed is 2 frames of mind are really, really important. I think the first thing is to realize that as upset and perhaps concerned as you are at this new and unexpected diagnosis, is that in this day and age, myeloma, the diagnosis of myeloma is not a death sentence in most cases, and that there's never been a better time. There's never a good time to be diagnosed with myeloma, but there's never been a better time to be diagnosed with myeloma because of all of the possibility and the rapidity with which new and marvelous treatments are coming down the line. So I think we have every reason to be more optimistic than we have in the past. The second thing would be right out of the chute and as soon as possible, and don't even debate about it, but seek the best care that you can get from people who are myeloma specialists, who have physician assistants and nurses and a whole team who really understand the ins and outs of myeloma. And that's easier for some if you live in a center where there's a university center and a special myeloma program than it is for those who live afar. But when we were diagnosed, there really wasn't anything to my satisfaction anyway that was available where we lived. And so we were willing to fly and to travel some distance to get the best care that we could. And it's just really worth the sacrifice and the effort. And to do that right up front and not resort to that as a salvage therapy after you've tried other things. I think the second thing is what we're all participating in right now, and that is to network, to not only get the best professional help that you can, but to participate in groups like Myeloma Crowd, the HealthTree University, and so on. That was really, really valuable to me, even though we'd gone to a center of excellent back east for our care. As meaningful as that was, to be able to talk to other patients who had already gone through that, had walked down the same road, and hear it from their perspective, that was almost as reassuring to me and comforting as it was talking to the health professionals. So for any of you who think that you might have got the shaft with a diagnosis of myeloma, realize that you've really hit a gold mine instead. In being exposed to the Myeloma Crowd and the HealthTree program. The third perspective that I think it's been helpful for me to realize is that just like that there is that cancer is not cancer, it's a whole cluster of different phenomena, all with their own prognoses and different hopes for outcomes. myeloma is all over the board. If you have 100 patients who have been diagnosed with myeloma, they each have a different story to tell. And we talk about low-risk myeloma, we talk about high-risk myeloma, and what we're learning positively is that many of the types of myeloma that have been characterized as high risk in the past now have treatments that are available that are making them much more treatable, and maybe it would be going too far to move something from a high risk to a low risk category, but at least the possibilities for treating these high risk cases are much more positive than they've been in the past. I think one of the things that's been most useful to me is to not let a diagnosis of myeloma define you. I have a little, I don't know whether this will come up on the screen. Says, I may not be totally perfect, but parts of me are excellent. Even now, 18 years later, people will talk to me and they'll say, well, how are you doing? And I know that in the back of their mind, they define me that way. They define me as somebody who has had cancer. And I just try really, really hard not to let that diagnosis define me. Yeah, I also have worn glasses since the 5th grade, and that's a relative disability. And I don't let the fact that I'm halfway blind discourage me from trying to negotiate as many paths as possible. And I think myeloma is the same way. I don't let it define me. Yep, I still worry about the fact that it's uncurable, but I look at all of the possibilities that allow that one year after another to allow me to keep marching down the road. At the same time, I do try to be realistic, and I realize that some of the side effects of my past treatments, some of which are permanent, some of which are reversible, that I do need to revise downward my expectations. I've got neuropathy, probably from the underlying disease itself, and some from the complications of drugs I've taken. And so when I used to hike mountain trails like Angel's Landing at Zion's National Park and so on that were a little bit treacherous, I just don't think that's a good idea anymore, and so I'm really, really careful about that. There's too many other cliffs to fall off without purposely exposing myself to that one. And so I work on my balance exercises and try to be really, really careful with that. The other thing is don't ever take a back seat in the care of your myeloma. You are in the driver's seat. The physician isn't, the nurse isn't, the team isn't. They're there to consult, to bring their expertise to bear on your case, but you are in the driver's seat. Don't be afraid to ask questions. The only dumb question is the one that you want to ask and don't. So when you go to your myeloma visits, always have a list of questions right at the very first of the visit. At the outset, say, here's what's concerning me, here's what I want to know, and I would like to leave having had the answers to those questions. Since even now when I go to visits, I sometimes feel like a fire hose is being aimed at with all the information. I like to have somebody along with me to listen and help me process and remember what's going on. And that leads me to my final point, and that is how important caregivers are, and a good caregiver. And all I'll say is that I've had the best caregiver in the world, and I'm going to turn some time over to her to just share a few thoughts.
Okay, you shouldn't have said that at the very end. Let me just tell. Okay, Audrey, tell a joke.
She's crying over the joke I just told her before we went on the air, and she said, "Please don't tell that one on the air."
Okay, he obeyed me. One thing John didn't tell you is that when he got diagnosed, he had, he's a public health physician. He had 200 employees. He's over 3 counties in northern Utah. And he went immediately from being a director and giving orders to being asked if he'd had certain vitals during each day. So it was kind of a high jump to kind of a curve that came at us. The one thing I would say in being a caregiver is you kind of have to get over the why me. We ate everything we were supposed to. We've had a garden for 50 years. We exercised, and myeloma gets you or something else will get you. So don't think that you're being targeted because of things, the why me in the past. I'm
going to interrupt here. I've gone from why me to why me. And as I look around now, I feel so fortunate to have been able to get good care, to have a great caregiver, to look at all of the people who I think are in much worse straits than I am. And so I've gone from a negative why me to a positive why me. And I just think that frame of mind is really helpful.
Sometimes the path that you think you're going down in life is not the path that you actually end up on. And, sometimes you can, the expression you can't control the wind, but you can control the sails. And that has kind of been our mantra, that we can decide how we're going to be affected by what happens to us. As a caregiver, I had just retired from running a business for 20 years. Been taking care of a mother who was going through some health issues in a city 2 hours away from us. And then he got diagnosed, and the community where we live is kind of high in the mountains, a couple of hours away from an airport. And when we got the diagnosis, we made the decision to find out where the most cases of myeloma were in the country being treated, and we took a place that was farther away. We are now closer to our home, which is just north of Salt Lake. So we are at Huntsman. The one thing I would say to caregivers is to dig in with both your feet and start running. Several reasons for that. Start running and getting your exercise, and whether it's a walk, whether it's weights, whether it's meditation, whatever brings you peace, I think you've got to allow time for that.
The greatest thing that brings me peace is doing what my caregiver tells me. Not doing that, it puts my life in greater danger than the myeloma.
I'm supposed to take 10 minutes.
I know.
Okay. I had been exercising, but I became more intent on that. I love to garden, doing that. So things physically that you enjoy. Now, the other part, I started educating myself. I had not handled insurance. He had done that while I ran another business. So I had to quickly understand what out-of-state things were being denied because we were going out of state. That was kind of a high mountain to climb. I started listening to audiobooks, and this would be while I exercised, just to take my mind and kind of feed my soul and strengthen me. Eating healthy, that's the one thing I would say to a caregiver and a patient. And I know HealthTree has had a webinar on that, of eating good food, whole food. I love sweets, but trying to mediate that with good wholesome food and good meals. That was the one thing that I found as a caregiver the patient was not thinking about. And I still to this day have to monitor that he's eating and drinking what he should. And it's not like I'm in his face, most of the time? Well, not all the time. Some of the time, just making sure, because I know the cancer that he deals with, hydrating and nutrition are huge as to how he feels and what other sidewinders we will be dealt with if we don't adhere to that. Also, a higher level than yourself. Find something where you have hope. Find something that brings you gratification and helps you give insight to what you're dealing with. The other thing as a caregiver, educate yourself. 18 years ago, when he got diagnosed, the words that the medications were like a page and a half long. They would say them to me, and I was, the glassy eyes kind of thing. It's so helpful if you start educating yourself as a caregiver, so that as you go into a medical visit, that you can kind of understand slowly what is going on, and then you're not at the will of the physicians. You need to have a background and a knowledge of what the medications are, what the side effects are, what you're dealing with, so that you become a team member on the cancer. One of the things that I have done since the beginning, and I'll show this to you. This is this is kind of my Bible. This is mine. It's just a book where when we have a visit or we have a phone call or we do something, I write down what happens or what medications are given to him and what reaction he had, so that when we go into something else or down the road, when your mind will become kind of foggy at points, trying to absorb everything, having it written down takes it out of your brain and onto paper. Listen to the experts, listen to doctors. One thing that pops into my mind right now is I would get to a doctor who deals pretty exclusively with myeloma. Get an expert. Physicians who are dealing with cancer, who deal with 200 different cancers, cannot physically and mentally keep up to date on that. I think getting to an expert, and I think they've broadcast this on HealthTree, that your outcome is far better, a higher percentage when you get to an expert than it would be if you're just with a general oncologist. You will have well-meaning friends who will have a cure for myeloma. I would advise you to thank them and then get back to the experts, because we come from a medical background, and it's proven over many years of marriage and education, that's who we go to get our best information. As you're dealing with cancer and myeloma, take time to play. Find some fun things that you enjoy doing. I can remember one night, late at night in Arkansas, where we were getting treated originally, that I'm trying to think what it was, at Wendy's. Can't even think the name of it.
Frosty.
Oh, a Frosty. I said to John, have you ever had a Frosty? Okay, so he was an office guy and in the office all the time. And he said, what's a Frosty? And I said, get in the car. We're going to go get a Frosty. So just take time to do the fun things you enjoy together, whether it's going to a park, going for a drive, having a treat, being with friends. Just find some positive things that's completely away from cancer, just to feed your soul in such a positive way. if you're dealing with a transplant right at the beginning, now we had stem cell transplants in 2003 where he had tandem, so 2, and then he had a relapse in 2018. So we went 15 years with remission, and we were doing great. When the relapse happened, at the time in 2003, we had some kids still in college, some kids just kind of launching out of the home. In 2018, he had just been instated as the mayor of our town that we're in, and that probably is what pushed him over. We don't know. But anyway, he had a relapse, and all our children had moved away and been launched, so we were kind of by ourselves. We chose one of our sons to kind of be the mouthpiece for us. Going through the transplant, you know, if you've been through a transplant, it's intense. It's intense 24/7. And I didn't want that responsibility of people texting me and saying, well, how's it going today? And me feeling obligated to give them the whole 9 yards. So we chose a son to communicate with everybody. They knew that they weren't to communicate with either John or I, John or me, as we went through this. And that was such a relief. I would advise you to do that. The other thing as a caregiver, when you see people in the store, or can we go to stores today? We don't know where we are on this. But as you see people and they ask, well, how are things going with John, or how are you two doing? I just gave a standard answer. We're doing fine. He's coming along great. I didn't want to get into the details with every person that knew us, and that will exhaust you. Just give a blanket answer and go on and have that son or caregiver give details to who you want details to go to. You need your energy as a caregiver to support the patient, to support them. One of the things that I really appreciate is medical science. When we started in 2003, there were, 2 or 3 options. And the hardest thing I ever did in my life, it wasn't the decision to marry John. The hardest thing I did was to sign my name on a clinical trial in 2003 when I couldn't really get on the internet to even read or know about clinical trials. That was really hard. Today, it's a breeze. Everybody's thought it through. Everybody knows clinical trials, and that obstacle is out of the way. The strides made in myeloma are breathtaking. There's just so much hope. There's so much smart medical science and doctors that have really helped us in that respect. The last thing I would say is just treat each day as a gift. You may feel crummy. You may feel not as crummy as the patient going through myeloma, and it may be a heavier day for you, but just give thanks that it's a gift, and to choose something to approach that day in a positive way, in a comforting way that not only helps your patient, but gives you energy to deal with what might be given to you. Just in closing, one of the things that we did, and for those of you who don't have a spouse or a partner to be with, one of the things that we decided going into myeloma, it was our disease. It wasn't John's, it was our disease. And I just became the expert, or picked up where I could see there was a void to help him navigate the best he could. Good luck to all of you. We know what you're going through, and we appreciate all that HealthTree is doing in the myeloma crowd to just open up the doors of this horrendous challenge that all of us have been through. Thank you.
Thank
We'll
you,
turn it back.
Ann.
There you go, Audrey. Okay.
Thank you so much, Ann, and thank you, John, too. I just love your story and your relationship. You guys are so fun, and thank you for sharing your story with us. Kelsey Dr. Barrell was having some trouble getting on, but we finally got her on. I love when technology works and trying to be patient when it doesn't work. So we're glad it worked today. And I'm going to introduce her, just give a little bio for her, and then we'll turn the time over to her. So let's see. I think this is working. There we go. Okay. My computer's running a little slow. Okay, can you all see that? Hopefully. So Dr. Barrell is an assistant professor in the Division of Neuromuscular Medicine within the Department of Neurology at the University of Utah. She completed internship, residency, and fellowship under the mentorship of Dr. Gordon Smith at the University of Utah, where she developed a passion for academic medicine and education. She is the neurologic, I'm sorry, I practice these words and then they don't come out well. Specialist in the regional amyloidosis program at the Huntsman Cancer Institute, and is helping develop a comprehensive multidisciplinary neuro-oncology clinic, which will cover a wide range of neuromuscular disorders. Kelsey, the time is, sorry, I have a friend named Kelsey, so I keep saying that how disrespectful.
That is fine. I go by Kelsey with all my patients, so
Okay.
let's just use Kelsey.
Okay, the time is now yours. Thank you for being here.
Wonderful. And I think because, let's see, you have the slides, are you able to advance?
Yeah, I will pull them up.
All right.
I just have to switch over.
All right. So I'm Kelsey. I am so happy to be here. Some of you may recognize me. I wish I could see everybody and present, but I can't. So thank you for those who returned, and wonderful to see new faces. I'm going to be talking today on managing peripheral neuropathy in the clinical setting. So what my patients have taught me, patterns I've seen, and hopefully this will be clinically relevant and interesting to you. I am happy to take questions as we go along so that we don't forget them. I won't be able to call on people because I'm talking from my cell phone due to some technical glitches. And so please just introduce yourself and speak out. I like to be interrupted. I love participation. So we'll kind of go from there. And how's it working from your standpoint, Audrey? I still don't see any slides.
I know. I just need 1 minute. It's because
no problem.
Freaking out. So sorry
no problem.
about that.
I think this is actually, I was looking at my slides and updating them to see, what new information I could add. And I realized this is my 4th year doing this. So that was kind of exciting. So I'm really grateful that Nico invited me back. I think this is my favorite platform, is talking with patients. I much prefer it than, compared to stuffy grand rounds in the hospital. So I always love actually seeing the people I get to work with. And it's really fun for me. Every once in a while, someone comes to clinic and they said, I've seen you before, even though I haven't met them clinically yet. And usually it's from one of these presentations. All right, looks like we're good. Okay, perfect. And so let's advance the slide. Great. So, and this is really small, so I'm going to go along on my computer. So sorry, my eye contact isn't good. So introduction. So what are we going to do? I want to start with the basics. What is a peripheral neuropathy, and what are the symptoms that people may discover? What are other types of neuropathy that may occur? How do we diagnose it, and what are risk factors that we may have? And what are the treatments that can both cause the neuropathy that we might have had in the setting of multiple myeloma or associated syndromes? What are the treatments of the neuropathic symptoms? And a little bit about future research. So we'll go to the next slide. So essentially what peripheral neuropathy is simply put, it's damage to the peripheral nerves. And this typically affects the longest nerves first. And this results in a stocking glove pattern. Stocking glove, if you can picture, the neuropathy starting in the toes, creeping up the legs until they reach knee, thigh high, and then starting in the fingertips. That's what stocking glove or length dependent pattern is. And why is that? Well, if you can see the nerve, the image here, there's a cell body with a nucleus, and that's where all the energy is produced. But that energy needs to reach down to that distal tip of those nerves to receive sensory information. So it's a long structure. If it was the width of a piece of spaghetti, it would go around a track. So you can imagine those longest nerves are most susceptible to damage. And that's why we typically, in the most classic form of neuropathy, experiences it in the toes first, but we'll go over some exceptions as well. So we can go to the next slide. And one of the most perplexing things for my patients is the symptoms. It seems like the great paradox of experiencing both lack of sensation, so numbness or loss of balance or loss of muscle strength, plus these abnormally painful symptoms, which can be burning, tingling, pins and needles, shock-like vibrations, you name it, I've heard it. And there's a reason for that. The reason being there's different nerves that carry different information. And so the smallest nerve fibers do not have any protection. Myelin is the protection, like insulation of a copper wire for your electrical, systems. Similarly, we have insulatory, what's called a myelin sheath, but those smallest nerves do not have insulation. So they're often injured first or early on. And those small fibers carry pain and temperature information. So when those are dysfunctional, people have abnormal temperature, sometimes burning hot or icy, dripping cold, pain, tingling, something called dysesthesia, where some kind of touch, like a massage or a sheet, instead of feeling comforting, will feel extra painful, abnormally painful. There are thinly myelinated or thinly protected nerves that carry autonomic symptoms. And if you don't know what autonomic symptoms are, we will get there in just 1 second. And then the larger nerve fibers that have a lot of insulation, so are usually affected later on in course, carry just gross sensation. And what I mean by that is sensation to just normal touch or to pressure. So that can result in numbness. And then lastly, the largest nerves carry information from your muscles. And so that can result in weakness. And often we have a combination of the above. So we'll move on to autonomic neuropathies. Now, autonomic neuropathies are probably the most bewildering set of symptoms because it can truly affect any organ system. And this is the system that is, if you've ever heard of the term fight or flight, rest and digest, these are things that help us run from a lion or help us sit and eat a meal. So these are involuntary things that go on in our body. Without our detection, we only notice them if they stop working. So starting head to toe to describe the most common autonomic symptoms, autonomic neuropathy can result in abnormal sweating. So usually reduced sweat, but rarely excessive sweat. It can also help your pupils constrict when you go out into the light, enlarge when you're in the dark to help you see more. And so people may have difficulty adjusting to light if they have autonomic neuropathy. One of the most common symptoms is lightheadedness with standing. The medical term for that is orthostatic hypotension. Orthostatic means upright, and hypotension means low blood pressure. So feeling lightheaded or like you're gonna faint with an upright posture is very common. And what causes that is the vessels, when we stand up against gravity, our vessels need to constrict really quickly to keep that blood going up to the brain to fight gravity. And if those vessels don't have autonomic regulation, they can't do that. And so the blood pools in our legs and therefore we get lightheaded and we don't have enough blood in our head when we stand up. Another really common subtype of autonomic symptoms is gastrointestinal symptoms. And this is anything digestive, things like diarrhea or constipation, often alternating diarrhea and constipation, poor appetite, something called early satiety, where you feel really full really quickly or really bloated really quickly. Urinary issues can also occur. So urinary retention, going really frequently or going really urgently, and even having incontinence, which means you urinate without meaning to. And then lastly, sexual dysfunction. So these are things like erectile dysfunction, most commonly. And these are underreported. And think about why that might be after you've heard them. Well, one, they are perceived as embarrassing, some of them. Two, a lot of people might not realize they're part of the neuropathy that might be related to their multiple myeloma or its treatment. So they just think it's something that their doctors wouldn't want to hear about. And then lastly, a lot of these symptoms might come with just natural aging, right? So men in the crowd, if you're over the age of 50, 60, you maybe heard of an enlarged prostate and some of the urinary symptoms that come from that. Sexual dysfunction can occur also with aging. So it can be hard to tell, is this due to aging process or is this due to autonomic neuropathy? And what I usually, the way I try to parse this out, and it's difficult sometimes, is the company my symptoms keep. So if someone has rapidly progressive or new symptoms, all of a sudden over the course of few months, they feel lightheaded with standing, they have new constipation or diarrhea, plus some sensory nerve symptoms, then I'm starting to think that this is autonomic. If they've had just 10 years of urinary symptoms, probably those urinary symptoms are not due to an underlying progressive neuropathy, if that makes sense. So the next type of symptoms, often when I show this next slide, people say, oh, that explains why I'm having trouble with my violin or XYZ. So carpal tunnel syndrome. I bet at least half of you have heard of this, whether you know what it means or not. You've probably heard of it. And it's the most common compressive neuropathy. And essentially, the symptoms that people will describe is numbness in the purple fingers shown here. So those first 3.5 fingers, so thumb, index, middle finger, and half of the ring finger will become numb. And often there will be pain felt at the wrist, maybe at the thumb, and maybe up the forearm. These symptoms tend to be initially provoked by certain activities such as typing, so things that are repetitive, driving, and then often they can wake people up from sleep. And why those triggers? Well, essentially what happens is that median nerve travels through the wrist, and at the wrist there's a narrow tunnel, and that tunnel is easily compressed by things that move the wrist in a flexed or extended position. So if you sleep with your elbows curved in, that's actually compressing that nerve and causing it to become symptomatic. If this has gone on for a while, symptoms go from being just episodic to persistent, and there can be associated weakness, often in the gripping muscles, like turning something or opening a bottle cap, or dropping items is a frequent symptom. And there are good treatment options that we're going to touch on in the end of our session. One thing I think is important to note is that usually people have it in their dominant hand. So if they're right-handed, usually it's right-handed. Sometimes it can happen in both hands. And when it does, I like to do a little workup looking for things that cause bilateral carpal tunnel. The most common one being diabetes, followed by hypothyroidism. These are common disorders, aren't they? So it's important to look for them. And then amyloidosis. Amyloidosis many have heard of because that is, in the spectrum of multiple myeloma, a lot of people start with an amyloid diagnosis, a monoclonal gammopathy, sometimes before receiving a diagnosis of full-on multiple myeloma. So that is a risk factor. We'll move on to diagnosis now. And diagnosis really just starts with a good exam. So exam checks different sensory modalities to pinprick, to temperature and vibration and joint position. I'll check strength and reflexes. So this is an exam that I can do over 5 minutes in a clinic. And a lot of oncologists can do a really basic neurologic exam and be able to kind of confirm a suspicion or at least screen for a neuropathy. Now, if we suspect a neuropathy, we can further confirm this using what's called a nerve conduction study, or EMG. And this is a procedure where we use a little electrical stimulation to map out how the nerves are responding. Because nerves essentially are just electrical wires. They carry electrical information, so we can actually shock the nerves and then record how they're working. And then the EMG portion is where we take a very small needle and I listen to the muscle and I listen for abnormal muscle activity that could suggest whether this is an active or chronic process. But it's important to note that a lot of times early in the course, when these neuropathies are just affecting those smallest nerve fibers, remember that picture of those unmyelinated small nerve fibers, this study can look normal. And so I don't need a nerve conduction study to really start working up and treating a neuropathy. I usually only use a nerve conduction study if I think it's important to confirm the diagnosis, if there's something atypical. And often I use it to show if the carpal tunnel syndrome is an active case that might need surgery. So not everybody needs a nerve conduction study. And it does feel kind of uncomfortable, like if anybody's had a static shock from a rug shock. My dad used to do that to me as a kid and I hated it. It feels kind of like that zap. Other diagnostic tools, a skin biopsy is where we actually take just a thin paper thickness section from a few sites in the leg, and we measure how dense the nerve fibers are in the skin's junction. It's the dermis epidermal junction. And so that's a really quantitative way. We can objectively kind of see how far along the neuropathy is. But this is something that's slightly invasive. And so usually we don't do that except if it's for research or there's something very unusual that we have to confirm it. It's important to rule out common factors of neuropathy that increase your likelihood of developing a neuropathy. So if I suspect a neuropathy, I'll always screen for diabetes. I'll always screen for vitamin B12 deficiency. And then I'll always screen for cholesterol because abnormal cholesterol can contribute to neuropathy as well. So if we move on to further diagnostic techniques, the autonomic neuropathy, usually I just get nosy. I ask kind of nosy questions about all those autonomic symptoms we just talked about. And usually based on a clinical history, I can assess whether there's some autonomic neuropathy at play. There is more dedicated autonomic testing, but this only occurs in a few regional centers. Actually, the University of Utah is one of them, which is very exciting that we can do some more kind of next wave of autonomic testing. And these are things where we test the autonomic parameters. So we do something called a tilt table test, where we measure your beat-to-beat blood pressure and heart rate when we tilt the body up. We quantify how much sweat you're able to produce, because sweat is a function of the nerves. And then we can measure heart rate variability. Now, moving on to risk factors. So if some people have heard of Occam's razor, this essentially is the principle that the simplest explanation, the one with the fewest assumptions, is usually the most accurate. And we always like when that's true in medicine, when there's just one thing going on. But often that's not the case, unfortunately, because, for instance, many people ask, why did I get a neuropathy in the setting of, say, chemotherapy when my best friend did not? We had the same dose, we had the same type of chemotherapy. What explains that variability? Well, there's been some very large studies, meta-analysis, where we take tons of different research studies and compile the information. And we found that there are some personal risk factors that increase likelihood of developing neuropathy in the setting of treatment for cancer. One of them, kind of obviously, is pre-existing neuropathy. If you have pre-existing neuropathy, that neuropathy is more likely to get worse in the setting of chemotherapy or some other kind of physical stressor. The other one is during chemotherapy, when you're actually receiving it, if you get some abnormal sensory symptoms, kind of waves of sensory symptoms, that might be an inkling that those nerves are more likely susceptible. But then there are some other personal risk factors like smoking history, if the kidney function's abnormal, as well as obesity. So those are personal risk factors. Those are things that we can modify as we go through life. And then we mentioned the acquired risk factors that we screen for: diabetes, B12, and high cholesterol. Now, moving on to treatment-related causes of neuropathy. Many of you have gone through a treatment course, and that could mean many things depending on what site you've been treated at. But when can neuropathy occur in the course of treatment? So actually at any point in time, even before treatment is started. And so it can be a result of the underlying cancer. It is estimated that about up to 20% of patients who have multiple myeloma will have neuropathy from the disease even before treatment is started. And similarly, if anybody has heard of or been diagnosed with AL amyloidosis, 40% of people, even before treatment, will have neuropathy as a result of their AL amyloidosis. Now, there also is a high prevalence with chemotherapy, and we'll move on to the most common chemotherapy agents. Transplant, there are sometimes that we can get it during transplant, and even after during graft versus host reactions. So moving on to chemotherapy-induced peripheral neuropathy. By and large, the most common agent in the setting of multiple myeloma to cause neuropathy is bortezomib, which is also called Velcade. And this is really one of the pillars of most multiple myeloma treatment. Works pretty well, but unfortunately it can cause a painful neuropathy. And so this usually occurs within the first few courses and then usually plateaus by cycle 5. It is common. 35 to 50% of patients receiving bortezomib will have a new neuropathy or worsening of their underlying neuropathy. And what's unique to bortezomib, I think, compared to a lot of the other chemotherapy-induced neuropathies, is that this can be exquisitely painful. Really, really hard to treat pain. And so many people really seek attention when the neuropathy becomes painful. Thalidomide was used in a lot of the older treatment courses, and it also has a very common neuropathy. And thalidomide's neuropathy can be more severe in that it can, in addition to causing pain, it can cause weakness and then autonomic symptoms, most commonly constipation. Lenalidomide is also very commonly used these days for multiple myeloma. Unfortunately, it's much less neurotoxic. It can cause a neuropathy. It's actually hard to find the prevalence data. So I think, certainly under 20%, and it tends to be a mild one that self-resolves. So lenalidomide is much less neurotoxic, fortunately. Now, vincristine, I don't know if anybody in this audience has received it. It's not as commonly used for multiple myeloma, but has been in the past and is used certainly frequently for other treatments. Vincristine is also a very common cause of neuropathy, and this can cause autonomic neuropathy in up to a third of patients. So that's an important one in a lot of patients, not necessarily this crowd maybe. Now, the mechanisms behind neurotoxicity, I show this slide just because I think it's interesting, but not necessarily to go through the nitty-gritty details. But the nerve, if we see the nerve coming from the spinal cord and going all the way to the nerve terminals, there's a lot of different parts of the nerve that can be injured by chemotherapy. One of the most common ones is the microtubules. Those are the structures that carry energy to the dendrites, to the end of the nerves, and bortezomib has a huge effect on microtubules. Mitochondria are the energy producers, so that can be a big place where the nerve is injured. The vessels are injured in thalidomide, so if you injure the vessels that supply the nerve, you injure the nerve. And then there's something at the very top called the dorsal root ganglion. And this is basically the start of the nerve, kind of one of the big major, the cell body of the nerve. And this does not have very much protection versus the rest of the nerve has a lot of protection. So this is a common site of chemotherapy-induced peripheral neuropathy too. Importantly, people want to know the scope and duration of symptoms. So they come to me and they say, I have symptoms. Is this ever going to resolve? What should I expect? And it's really disheartening because a lot of people have dealt with a really hard, scary course where they're fighting cancer, they're dealing with chemotherapy, only to realize that their course has led to another problem. They thought they dealt with one problem and now they have another problem, which is neuropathy. And unfortunately, across the board and anybody receiving chemotherapy, it's common. So 30 to 68% of people receiving any type of chemotherapy will have neuropathy. Symptoms, the good news is symptoms usually improve and stabilize when chemotherapy is stopped. So almost 100% of the time, the neuropathy will, at the very least, stabilize and not get worse, or it will improve once chemotherapy is stopped. There is one small exception, and it's called the coasting phenomenon, which represents worsening of symptoms for several months after the chemo stopped. But after 2 to 3 months, you will no longer have the coasting phenomenon, and it should stabilize or improve. 1/3 of patients will be left with permanent symptoms. So that means 2/3 of patients will have resolution of their symptoms, and there's no good way, unfortunately, of predicting who will have those persistent symptoms, other than we kind of discuss some of the risk factors that make it more likely to have them. So this does persist in a lot of people. And one big question is, well, at what point will I know if this is going to be persistent or not? Is it 3 months? Is it a year? I usually think if it hasn't resolved by 2 years, it probably won't. But nerves heal slowly, about 1 inch a month. And so even if it's 6 months, a year, I still carry hope that it could continue to improve. All right. We move to the next slide, and I see that there are some comments, some questions. I'm not able to read them, so at the very end, I'll maybe have Audrey read out the chat while people ask questions. So transplant-related neuropathy. Some of you guys have had autologous stem cell or a hematopoietic transplant, and so this is very rare. But sometimes you can get an immune-mediated neuropathy. So there's a lot of immunologic shifts during transplant, and in less than 0.3% of patients, they will have an immune neuropathy, which can vary. Sometimes that can be a very focused, severe neuropathy, such as affecting, a nerve in the face. Often, I've only seen 2 cases of this, but the 2 cases I've seen is what's called a plexopathy. And the plexus is where the nerves kind of form a webwork between the neck and the upper arm. So kind of in the underarm area, it's called the plexus. And this is, for whatever reason, a target to immune-mediated neuropathies. And then after transplant, people are on some new agents. So a lot of immune suppressants, and tacrolimus, as well as cyclosporin, have been known to cause optic neuropathy, which can lead to reduced color vision or visual acuity. Sirolimus usually only causes this when it's in combination with one of those first mentioned medications. Prednisone is very commonly used. And chronic prednisone, so over 4 months of prednisone at high doses, over 40 milligrams, can lead to muscle weakness in some. And then there are some immunologic agents, such as infliximab or etanercept, and rarely those can also cause a very specific immune-related neuropathy called Guillain-Barré syndrome. This is a rapidly progressive neuropathy that causes weakness and sensory loss over weeks to months. Graft versus host disease rarely affects the neurologic system. And so next slide, yeah. And when it does, it's usually only in the chronic form of graft versus host disease. And it tends to more likely affect the peripheral nervous system. So rarely can cause a neuropathy that would result in weakness. More frequently affects the muscle, and this can lead to muscle cramps in up to 16% of patients. I think this is really underreported because a lot of people, again, maybe they had muscle cramps before, just, you know, from dehydration or exercise, and just didn't make this link to graft versus host. But it's important to mention it to your physician or your care provider if it's really painful, frequent, and disabling muscle cramps, because there are some medications that can help with that. And then rarely it can cause headaches or more central side effects. So moving on to treatment. So the two main tenets of treatment, so kind of I think of two main pillars. Of course, the goal is targeting or preventing a neuropathy from happening. And often that's actually treating the underlying disease course. And so if you have multiple myeloma or light chain amyloidosis, you treat that underlying disease course. And often if your neuropathy is due to that disease course, that neuropathy can improve with time. And then another big item that can change your neuropathy is if it's thought to be chemotherapy induced. Reducing the dose or switching to another agent can, you know, prevent further neuropathy or hasten recovery. And then we mentioned risk factors. So it's always important to look for and treat the common risk factors, because these risk factors are common. It's really common that when I look for these, I'll find at least one. And that can be something as subtle as elevated triglycerides or elevated cholesterol. And then exercise can help the underlying nerves. And we'll talk a little bit more about exercise in a second. And then the other pillar of treatment is targeting the symptoms. And our medications work mostly on the painful features, the burning, tingling, extra kind of shocky pins and needles like type sensation. Unfortunately, if you are only suffering from numbness, our medications do not actually treat the numbness. And there's both topical and oral treatments that target symptoms. So moving on to exercise, what is the data? So I want to first start by saying, unfortunately, this has been really well studied in cancer and is a preventative strategy, and they have not found that an exercise routine actually can prevent people from getting neuropathy. But in people who have neuropathy, and this can be any form of neuropathy, whether it's cancer, chemotherapy, or diabetic related, exercise does do something. And this isn't just a soft recommendation, oh, exercise does the body well, you lose a little weight, you feel good, sleep better. There are actually some objective findings. And so I'm going to walk you through this study because I think it's pretty exciting. So at the beginning of this one particular study that was actually done in part at the University of Utah by some of my mentors, they took a skin biopsy of all of the patients enrolled in their study. In the skin biopsy, again, lets us quantify the density, how many nerves are in the skin. And the more dense or the higher number of nerves is a better thing. You want to have a lot of nerves at the surface of your skin to receive information. Now, about half of those patients did standard of care, which is they see their doctors every quarter, and their doctors might put a plug, you should exercise and eat better, right? That's kind of what happens in clinic. You hear it, but you don't actually have a great idea always of how to achieve that. And then the other group actually had a more rigorous counseling. So this was bi-weekly access to a nutritionist plus a coach that guided a 5-day-a-week cardiovascular exercise routine where you push it. Every month you kind of work a little bit harder so that you're always getting, that sweating in that workout. And then after 12 months, they repeated that biopsy. And now if we think about the nerves and we think about, you know, someone with a progressive neuropathy, it would make sense that after a year that we would have less dense nerves, that we would have a lower number, a lower density. And after a year, if we had a positive intervention, maybe we wouldn't have that nerve drop off. Maybe we would have the same degree of density, so no change. But actually what they found in this trial, and this has been repeated since this time in a few other trials, they found something better. So if you look at this table on the right, you see all those numbers on the vertical axis, and you see, you know, a 0 there. That would be no change. And you see in the white, which is just the standard of care counseling, you see that they kind of lost a little bit of density in the ankle. And the ankle really represents early neuropathy. Remember, it's length dependent. So the thigh, you can kind of cast out the thigh. In the ankle, you lost a little density, which makes sense. But in the treatment arm, in the gray bar, what is really interesting that after a year, you actually improve the density. You gain nerve fibers. And what they think is happening is that it bolstered your own regenerative capacity. As we age, our nerves are dying back, unfortunately. Past the age of 20, a lot of things are dying back, our hair, cells, but our nerves are dying back. But our nerves are also regenerating and growing as we go through life. But unfortunately, with as aging goes on, or if we add a neuropathy, our regeneration can't keep pace with the dying back of the nerves. And so this just bolsters that regenerative capacity. And also, of course, exercise helps other things. It helps control diabetes, cholesterol, mood. Actually, it's been shown to lower risk of Alzheimer's, dementia. So there's a lot of reasons that we should exercise, but bolstering your nerve health is now one of them. So I always recommend to my patients to work out for 30 minutes, 5 days a week. That is the goal. You don't have to start there. And that should be something where you break a sweat. I don't care what people are doing, whether it's walking, some kind of exercise, bike, rowing machine, swimming, you name it. But I want them to actually get a workout. So people will ask me, oh, I work in the yard all day long. Does that count? Nope. Stop and go does not count. It is 30 minutes of sustained cardiovascular exercise to give you a sense of, if you're not a sweater, what this would feel like. You might be able to have a breathy conversation, but you're not able to sing a song. Okay. So moving on, this is kind of just an update. So the American Society of Clinical Oncology always puts out practice guidelines every few years. And a big hot topic is, how do we prevent chemotherapy-induced peripheral neuropathy? It's such a problem. It's a growing problem, in fact, because people are living longer, our treatments are working better. And so as a result, there's more chemotherapy-induced peripheral neuropathy. Tons of trials were sifted through to come up with these practice guidelines. And these are the updates. So really no big positive trials, unfortunately. They discouraged the use of something called acetyl L-carnitine. And they found that this actually can worsen a neuropathy. And then outside of the context of a clinical trial, there really were no recommendations on some of the alternative therapies. So a lot of times patients ask me about acupuncture, something called cryotherapy, where you wear cold gloves during chemotherapy. Compression therapy is tight-fitting gloves. And then some fatty acids or other supplements. And no recommendations are made because there are many trials, but none of them showed a statistically significant benefit. And then there were tons, and this is just actually probably the most common, third of supplements that have been studied, but there are tons of supplements that they actually said clinicians should not offer the following things as prevention because it didn't add anything, it didn't help. These are things like calcium, magnesium, L-carnosine, glutamate, glutathione. These are a lot of antioxidants, omega-3 fatty acids. This doesn't mean it's going to harm your neuropathy. This just means it's not going to prevent it. Okay, vitamin B, vitamin E. So if you're already taking omega-3 fatty acids for your eye health, keep doing that. but this just shows that it isn't actually preventing neuropathy. So clinicians don't need to prescribe them. And then moving on, thank you, Audrey, to topical treatments. These all are equally effective to one another in clinical trials. And it's a nice way to start if people have mild symptoms that are really like focused on the feet, because there really aren't side effects to these. They don't really get absorbed in your system and sedate you or cause swelling or anything. Lidocaine ointment and lidocaine patches can be obtained over the counter. And capsaicin is actually the active ingredient in chili. So that's one thing that people try, and some people feel like it works. It kind of deadens the nerves temporarily, the responsiveness to the nerves. Compounded ointments are ointments that actually compounding pharmacy mixes up. And so I have kind of an ingredient list of things that I ask a compounding pharmacy to mix up. So it includes a lot of different things: ketamine, gabapentin, amitriptyline, baclofen, clonidine, and a few other things. And then a hot topic is CBD. If you haven't heard of CBD, it is the pain fighting component of cannabis, better known as the marijuana plant. And so there are ointments and tinctures. Legality varies by state. So these are best studied actually in Europe and Canada, and have gained a lot of traction in the treatment of cancer-related symptoms, both nausea as well as pain. And at least in the state of Utah, where I am, there is medical marijuana that's legal. And CBD, a lot of times, if it only has a small component of THC is what makes people more euphoric or centrally acting, makes people happy or drowsy, depending on the person. If you have just a small portion of THC, you can buy it at the store. So my patients often are going to their nature store, or going on Amazon online and getting CBD. And in my clinical experience, CBD products, especially when they're broad spectrum, which means they have just a sniff of THC, are as effective as any of the other topicals. So that is kind of, there's still a lot unknown because we haven't studied it much in the US yet, because it was considered kind of a drug of abuse up until recently. Now more treatments, moving on to oral medications. There are a handful. These are the 4 most common ones that I use in clinic. They are all equally effective. And so I pick which one I'm going to use for a patient based on side effect profiles, as well as maybe other symptoms that these medications may treat. There are the 2 oldest ones. So often I'll pick one of the oldest ones, which have really good track records. So we know all the side effect profiles, and they're dirt cheap. So gabapentin, which is also called Neurontin, is very effective. It doesn't cost much. The side effects are not in everybody. So it's a minority of patients that will have the side effects. But when they do have side effects, the things that people are most likely to complain of are mild sedation, like a head fog, or swelling. And this often happens on initiation. And a lot of times people get used to it. That's why I usually start at a low dose and then slowly titrate up to a higher dose. Amitriptyline, also called Elavil, is actually a very old medication that used to be used as an antidepressant, but it made people too tired. So we now have better options for depression alone. But the good is that it also is cheap, and it can help insomnia. So people are having a lot of trouble falling asleep. I use this actually as a sleep aid. It also can help at higher doses with depression. And as an aside, if people have migraine headaches, it's a great migraine preventative strategy. The side effects that people may see, again, not in everybody, it can dry people out. So it can cause dry mouth or dry bowels. So if you have diarrhea, this is great. It dries up your bowels a little bit. If you have constipation, maybe not what you want to take. And it can make people sleepy, which again, I prescribe at night. So usually that's not a problematic side effect. Pregabalin also called Lyrica. Maybe you've seen this on computer or TV ads. This is essentially the next generation of gabapentin. So it's equally effective to gabapentin, and it tends to have fewer side effects than gabapentin. So less head fog. So if someone is having side effects on gabapentin, but it works well, I will then transition them to pregabalin. Now, why don't I start everybody on pregabalin? Well, because a lot of people tolerate gabapentin great, and pregabalin is 10 times as expensive. Usually insurance covers a lot of that, but still, it ends up being more expensive. Now, the last one, Cymbalta, also called duloxetine, is an agent that is used probably the most in chemotherapy-induced peripheral neuropathy because it has been best studied. The best, largest trials in neuropathy were with duloxetine. It does not mean it works better than the other trials. It just means the other medications did not have as big a trials for chemotherapy specifically. And some of the benefits, in addition to fighting your nerve pain, is that it also helps with other types of pain. It really helps with muscular or back pain. It's a gold standard agent for something called fibromyalgia, which is where people have aches all over, muscle and joint pain. And the dose I use for neuropathy, which is just kind of the medium average dose, it is an antidepressant. It works very well for mood. And it does not tend to be sedating. So most people actually might get a little pep in their step, a little energy. So I prescribe it in the morning so that won't keep them up at night. And then, the downside is just that it is a newer, more expensive medication. But again, most insurances will cover this. And I'm looking at the time, and I started about 5 minutes late. Is it okay if I go to 12:05? Yeah, okay. So autonomic neuropathy, we talked about all the many symptoms. So it really is based on what symptoms you have. And so if your symptom is the lightheadedness with standing, called orthostatic hypotension, there's a lot of behavioral modifications that we start with. And those include compression stockings. They work best if they go above your knee. I know my picture is below the knee. I couldn't find a nice one above the knee, but thigh highs work best. That keeps the fluid from pooling in your legs. So it keeps the fluid up close to your heart and your brain. And it has to be medical grade, which is measured in millimeters of mercury. 15 to 20 is what to look for if you're buying them on Amazon or if any medical supply shop. Similar abdominal binders similarly keep fluid from pooling in around the gut. And then hydration. If you're allowed, as long as you don't have congestive heart failure, it's important to get 2 to 3 liters of water per day. That's about 3 of these. I don't know if you guys can see me as I'm talking, but 3 standard water bottles. And often if this symptom's really a problem, I have patients take half of that in sports, like electrolyte drinks, and half of that is water, because those electrolytes help keep fluid in the vessels. And speaking of keeping fluid in the vessels, salt. That is one of the important reasons that salt is important for us. And salt essentially keeps the fluid in our vascular spaces. And so again, as long as you're allowed to, from a primary care standpoint, you don't have sky high blood pressure or heart issues, actually making sure you get enough salt is helpful for this symptom. So about 3 grams per day, but that does not fit for everyone because there's reasons that I mentioned why you don't want a heavy salt diet. Another simple one is raising the head of your bed about 6 inches so that the entire bed is tilted 10 to 20 degrees. No putting pillows at the head side of your bed does not count. You actually have to tilt the entire bed. So I tell people buy cinder blocks that are about 6 inches high, put them under your headboards. And what does this do? Well, first of all, it gets your body used to a little bit of gravity, and it reduces your body's natural autodiuresis, which means it reduces the amount of urine that you generate over the night and in the morning so that you keep fluid in your body. Also is nice if you're having trouble urinating frequently at night, this can help a little bit. If those behavioral modifications don't help, then I move on to medications, and there's 2 main medications I use, and depending on the patient, I might use one over the other. Those are midodrine and fludrocortisone, also called Florinef. Now moving on to gut issues. So gastroparesis means slow gut. And so if people are having trouble moving their bowels, they feel bloated, they get full too much, they feel constipated, likely they have slow gut motility. And often dietary modifications can help a lot. Smaller meals, so regular meals, not having big, large boluses, but small meals. Having low fat and low insoluble fiber. So soluble fiber is good, like Metamucil, but insoluble is like really hard to break down items in the food. Liquid nutrition is always easier, so supplementing some, protein shake. Avoiding carbonated beverages, smoking and alcohol. Those things can make digestion harder. And then staying hydrated and moving, actually. So normal movement, not being a couch potato, and regular hydration helps gut motility. Now, for urinary symptoms, there's a lot of medications that primary care physicians feel very comfortable with. And then likewise for erectile dysfunction, there are many medications that primary care usually is able to prescribe. So I usually rely on primary care to help me treat those two, because they're very familiar with those agents. I mentioned earlier that carpal tunnel syndrome, it's one of my favorite things to diagnose electrically when I'm doing the electrical testing, because it is so responsive to treatment. And the first treatment I try is a neutral wrist splint, a splint that looks like this, and you wear it to prevent your wrist from bending too much in either position. And interestingly, you only have to wear it at night. So the indication is all night long for at least 6 weeks. Often that makes symptoms improve or resolve. Now, if that doesn't help or you don't tolerate it, it makes the pain worse, then I usually refer on to a hand surgeon. And they can try steroid injections, which can really temporize or help with the symptoms, but don't really treat the underlying course. And so if their patients are a good candidate, often they'll go on to have what's called a carpal tunnel surgery, carpal tunnel release. And I don't usually recommend many surgeries because I'm a conservative person. I say, let's manage things non-surgically. This is a surgery that's an exception. I have a low threshold to say, yes, let's refer you to get this carpal tunnel release because it's minimally invasive. So essentially what they're doing is, I mentioned it's a compression neuropathy. There is a dense ligament over your wrist that is compressing that nerve every time you move it. And so all they have to do is make a small incision and cut that ligament so that your nerve is no longer being compressed. So it is minimally invasive and it is very successful. All right. And I want to make sure there's a lot of questions. So I want to make sure I leave time for questions. Future directions. I'm going to be very honest with you. I like to end with like future, where we're going next. But a lot of the future directions are still really in research and not clinically applicable. And these are things like finding genetic propensities for having a neuropathy. So trying to identify who's going to get it. And it's not clinically relevant yet. It's just what we're researching. And then advanced imaging is another way to look at how we're processing pain. And this might indicate who might respond better to like centrally acting medications like antidepressants versus peripherally acting medications. So this is stuff that is not yet hitting the clinic. So that's why I'm jumping through it, because I want to thank you, first of all, for your time. That hour went quick. I don't know if it felt that quick for you, but that felt really quick for me. And I saw a lot of good questions floating across my screen as comments. So Audrey, would you be able to read the questions? And when is this section supposed to be done? When's the Q&A supposed to be done? So I know how many questions.
Yeah, we're supposed to be done around 12:15.
Perfect. Oh, good. 15 minutes is great. Wonderful.
And then we'll do some outro announcements and shares. So
that's great.
All right, we'll cruise through as many as possible. Let me get to where it started, and just try to do this as quick as possible. So one of the questions, just to hit, one of the easier ones, the thalidomide, does that include Revlimid and Pomalyst? Excuse me.
Oh, actually, I'm able to pull them up. Oops. Let me see. So let's see.
They were just asking when you were talking about treatment-related neuropathy.
Yeah.
They were just trying to clarify, what does Revlimid and Pomalyst fall under in that?
Correct. So the newer agents, so there are more than just the lenalidomide. Those are all less neurotoxic. I think they get more, in general, less neurotoxic. Like the more recently, they've come to reached kind of clinical awareness, because that's one of the big reasons we're working on new chemotherapies, is because of side effect profiles, trying to improve side effects. Because thalidomide worked great on the myeloma. It just was had a lot of side effects.
Right.
And one of the big ones is if you were pregnant, you couldn't be on it. It could injure the embryo, which was the biggest one. And I'm actually able to go through these.
I think I'll still read them if you don't mind, because I'm going to try to filter some out just because there's so many, and try to
Okay, perfect.
just
Yeah.
like take out what has been repeated.
Uh-huh.
So you did answer what happens generally to neuropathy symptoms if chemo dose is decreased. Sometimes that works, you said.
Yeah. So often neuropathy will improve, if not go away. It depends on how dose reduced it is, and how bad the neuropathy is. But that will hopefully stop the trajectory. So if you're kind of getting worse, that will hopefully stop that, progressive upward slope.
Okay. Let's talk about long-term use of lenalidomide. Does that cause progressive neuropathy?
So it has a lower likelihood of causing neuropathy. So some patients will have a neuropathy due to that, but it is a minority, and that usually is a very mild neuropathy that tends to be more responsive to ending the course. So when you're done, it usually doesn't linger as much as the bortezomib related neuropathy.
Okay. How much neuropathy is acceptable before switching meds is necessary? With mild neuropathy, it's annoying but tolerable. Does it get worse, or do you suggest you stay the course as long as it doesn't get worse?
That is such a good question. That is a hard question, and often it is answered in discussion with your hematologist or oncologist. And so it depends on how much the neuropathy is. So a few big factors. One, how much is the neuropathy impacting your quality of life? If it's really bad, if you're miserable and you just don't think you can carry on this way, well, that is a good reason to think about switching. And then another big factor from the oncologist perspective, or the hematologist oncologist perspective, is, have you been on a pretty full course of chemotherapy? How is your cancer responding? So how's the myeloma responding? If you've had really good and complete response, there's probably more wiggle room to stop early or switch or dose reduce. And so really it's a risk benefit conversation with you and your providers to decide at what point is this neuropathy unacceptable. Because if it's just some mild tingling numbness and it's kind of background noise, it's not getting worse quickly, it doesn't impact many parts of your life, then yeah, that might be something we accept. But if you're not able to sleep, you're not able to recreate, you're miserable, then maybe we cannot accept that.
Okay. I think that helps. Thank you. Are leg cramps related to neuropathy?
Really good question. Yes. So leg cramps are related to a lot of things. So you can get leg cramps just from dehydration, electrolytes, certain medications like statin therapy, which is the cholesterol medications, can cause leg cramps. But people who have a progressive neuropathy are more likely to get leg cramps. And then we also mentioned chronic graft versus host. That's a common situation where you'll have leg cramps. One thing I forgot to mention, but might be relevant to a few of you guys, is when you have a progressive neuropathy, it's more likely that you'll develop something called restless leg syndrome. And it's what it sounds like. So it's when you're resting, in the evening or when you're watching TV, but usually before you're going to bed, legs up, you're relaxing. Your legs just feel this discomfort, this need to move. Moving, it helps, but then that discomfort builds and builds. So, so restless leg syndrome and cramping is going to be more likely when there's underlying neuropathy.
Okay, thank you. Is there a relationship between neuropathy and Darzalex or daratumumab?
Daratumumab, I have not seen I think maybe there's a few case reports, but I've looked at like the large studies, and I have not seen a big indication that that is a neurotoxic agent.
Okay, thank you. Let's go to some questions from people that have raised their hands. Let me see in what order people raise their hands, because I want to make it fair for everyone. Just 1 minute. Okay, we have Bob Drossler, if you want to ask your question. Bob, I don't know if you can hear us because I don't see your face, but and then if he is not available, we have Lavis.
Yeah, I'm here.
Okay, perfect.
I had a pain doctor tell me recently that gabapentin is now on the controlled substance list because it's caused memory loss in rats. And I've been taking gabapentin for years now because of my neuropathy. Should I get away from? Do you agree to that? And should I stop taking it?
So if we followed so my understanding of why it's on the controlled substance list is actually different. It's not based on rat studies, because it's rare that we use rat studies to decide what to do with humans, because a lot of times drugs work in rats or they don't, and that actually doesn't have a strong bearing on the clinical trials when we go on to the next phases of clinical trials. So rat studies, it's really hard to extrapolate. I think the big reason that gabapentin is on the controlled substance list, a lot of pharmacists I've talked to, we've had a long discussion. This is an inappropriate medication to have on that, because they're saying that there could be abuse potential. And so people who were already usually taking other sedating medications like heroin or opioids were taking gabapentin at the same time because it added to the sedation. And so usually it was used in combination on the street. But if you use it as prescribed, it does not have a strongly addictive profile. I don't feel like my patients are getting addicted to it because it's not particularly fun. It's not a good time. And so I don't know kind of that leap from the rat trial to humans, but in my practice, we have not been overly alarmed. I think compared to a lot of medications out there, gabapentin is very safe and well tolerated.
Would you say that 2 tablets a day is kind of a low dose?
That is a low dose. So thanks for mentioning dosing, because I did not add dosages for this lecture, but I use up to 3,600 milligrams a day, which is 1,200 milligrams 3 times a day.
Wow.
And often I'll start with 300 milligrams 3 times a day, unless I think someone's very sensitive to medications or is on other sedating medications. In that case, I'll use 100 3 times a day. So you can see from 100 3 times a day. Some people take it twice a day. That's fine too. I find that, it has a short half-life. To 3,600 in a day, there is a lot of wiggle room. Some people need a very low dose. But if people are on a low dose and say, it's not helping my neuropathy, I don't say gabapentin's not working for you. I increase the dose, because we probably just haven't found the right dose for them.
That's really helpful. Thank you so much. Darlene is saying she has MGUS and was recently diagnosed with small fiber neuropathy. She has several labs, all which have come back negative. So will this get better in time, or do you think it will worsen?
So Darlene, do you mean that your MGUS labs have normalized? Like you no longer have the labs that indicated MGUS? Or those have?
No, I still have the labs. The labs I'm talking about with the B12. They've done AC1. They've done all kinds of labs to determine what is causing consecutive. The last
Yeah.
one that hasn't come back is Fabry, and I don't know what Fabry is.
Okay, that's
That's
a
the one
really
that hasn't come
rare
back.
genetic cause of
Yeah, and I don't think
neuropathy.
I have that.
No,
That was
it
the
would
last
be-
test they did.
they're being very comprehensive. Wow.
Yeah.
So, Darlene, long story short, we can't say. So MGUS is interested. For those who don't know what it is, it's monoclonal gammopathy of uncertain significance. And MGUS increases your risk of neuropathy. So people with MGUS are more likely to get neuropathy, but not everybody with MGUS has neuropathy. So in some people, if they have neuropathy and MGUS, we can't say 100% it was the MGUS causing it, because in my practice outside of the cancer world, 40% of neuropathy patients have no explanation. We call it idiopathic. So some people just get neuropathy and we never find out why. So it's always hard to say for sure if the MGUS is causing it or not. But in general, if we don't find a risk factor to treat like diabetes or B12, that neuropathy probably won't just reverse on its own. It won't just get better on its own. But often neuropathies progress really slowly. And so one question people have, they say, you know, I have numbness in my toes. I can live with that. It's a little painful. Medications help. But is this going to lead to me being wheelchair bound in the future? Like what should I expect? And the answer is no. These types of slowly progressive small fiber neuropathies, so kind of painful, tingling neuropathies, are a nuisance. They can affect balance, they can cause pain, maybe a little weakness. They usually don't cause enough weakness to prevent walking though. They don't lead to significant weakness.
Great, thank you.
Thank you. We'll end with the Bailey's question, and then we'll go into our outro. So, Bailey's, did you have a question? I see your hand raised. You didn't have a question, or you can't unmute? I can't tell.
No, we don't have a question. I was just showing John all the things.
All the buttons?
Okay, we're fine.
Okay, perfect.
Can I pick one of these questions? So I just wanted
course.
to, Janet Sherman said, so we're not recommending vitamin B. Does this include B12? So my answer about vitamins. So they're not recommending any of those supplements, vitamins, to prevent neuropathy. But if you have a low vitamin, B12, B1, B6, I will replace that. So I will treat low vitamins, but I do not just prescribe vitamins, willy-nilly. I, only prescribe them if they're low. So I screen for a lot of vitamins and I prescribe if they're low, because otherwise our bodies are smart. It takes what it needs. So if it needs vitamins, it holds on to it. Otherwise, you're making expensive urine. You're peeing it out.
Awesome. Thank you. Are there any other questions on that list that we didn't get to? I know we weren't able to get to all of them. So do you see any others that you would like to answer?
So, Janet, again, good questions. So asked what we recommend for leg cramps. So there actually are some over-the-counter things you can try that sounds like witchery, but actually have been shown to help many people. And you're going to think I'm crazy, but pickle juice. Having a shot of pickle juice, we don't know exactly why, a few times a day can really help. The other thing is quinine, which used to be prescribed for malaria, but now we can't get in the US unless, you have malaria. So you can't really get it unless you go to Canada. But old good quality tonic water has quinine. So you can look on the label, and if it's tonic water with quinine, you can make yourself a cocktail. It doesn't have to have alcohol, it's just tonic water with quinine and some lime juice. And that, drinking that regularly a few times a day can help with cramps. A big one is heat and massage. So if they happen at night, taking a bath, massaging and stretching. And then if those things don't help, there are medications. Gabapentin is the one I start with that can help with muscle cramps.
Awesome. Thank you. Can you speak to mustard as well? I've heard a spoonful of mustard can help with cramps.
So that is not one that I know, but never say never, because I have a colleague who is smart and not a fanciful person, and he swears that sleeping on a thing of soap, hard soap under the pillow is helpful. So never say never. You know, what I would say is if it works, great. Can't
Okay.
hurt. Just make
Okay.
sure it's on something delicious like a grilled cheese. I always like mustard on grilled cheeses.
All right, we'll have Diane, who just raised her hand, and then we really will finish. So Diane, go ahead. Oh, you're muted, Diane, so for you can unmute yourself. Just click that microphone button. Perfect. Oh shoot, I still can't hear you, even though it says you're unmuted. Not
Diane, are you able to type it into the chat?
Diane, if you can, type it into the chat, and we'll give the time over to Nico, who's going to introduce somebody, and then we will finish. So is Nico still on? If not, I'll give the time.
Hi.
Okay.
We have Kelly Cox joining us today. Here he is. For those of you who kind of connected with this group through me or through Huntsman or through our in-person meetings at Huntsman, Kelly's the person, and the International Myeloma Foundation is the group that really helped get us those meetings off the ground, just supporting us. And when we had 8 people on a Saturday in 2016 to now, today we had over 100. And so Kelly and the International Myeloma Foundation are a really big part of getting us to where we are today. Now we've connected with our myeloma crowd group, which is national, but also locally grown product. And but I wanted to kind of keep connections with both organizations. Wanted to hear from International Myeloma Foundation. And since we're running low on time, I just wanted Kelly to be able to speak for just a few minutes, and then we'll have him back for a later meeting for a longer, more full presentation on what the IMF does for myeloma patients. So I will turn it over to Kelly. Thank you.
I'll be quick. You guys have gotten a lot of information today, and what a great talk or talks. So as I said, I'll be quick. Our website is myeloma.org. Now you have a lot of foundations out there helping you out. You've got to find one comment here. You've got to find the one that you fit with, or the jacket fits you comfortably. Never in the history of myeloma treatment or myeloma research has it been so many things. Now that means scientific research, et cetera, going on as there is today. Please keep our website in your thoughts. It's myeloma.org. And the next meeting, I'll go into deeper items about the IMF as it stands and what we do about talking about COVID, and Dr. Dury and Dr. McHale. These are all people that I feel trustworthy. I trust them to say what they should say. So that's it. What a long day for all you guys. I hope to talk to you soon.
Thank you, Kelly. Sorry that the timing was off, but thank you for sharing that. And we'll include it in our resources in our follow-up email as well. All right.
Thank you.
We'll finish off just by saying thank you for joining us. I normally do some outro announcements, but we're out of time, so I'll just say thank you to our sponsors. Thank you to each of you for joining us, and we will be in contact about when we can see each other again. So thank you for coming, and hope that you have a great rest of your day. Thank you.